This demonstration shows an implant placement in a young female patient with a congenitally missing lateral incisor of the maxilla. The implant will be inserted with a simultaneous GBR procedure to augment an apical fenestration defect. The patient is 18 years old. She was referred to the clinic with a single tooth gap in the anterior maxilla. Tooth number 22 was congenitally missing, whereas tooth number 12 had a deformity. The radiographs demonstrate a crowding of the front teeth in the maxilla. This condition first required orthodontic therapy to realign the teeth and to create sufficient space in area 22 for an implant. The clinical view shows the status following orthodontics. The teeth are now properly positioned. Tooth number 12 will be corrected with a veneer, and the missing tooth number 22 will be replaced with an implant-supported crown. The periapical radiographs demonstrate that tooth number 12 was successfully realigned, whereas the space in area 22 was sufficiently opened for implant placement. The clinical status at implant surgery shows the alveolar crest with a facial undercut that will lead to an apical fenestration defect after implant placement. The mirror view highlights the soft tissue status with a thin gingiva. It shows sufficient soft tissue height for an aesthetically pleasing result. The surgery begins with a palatal incision in the crestal area using a 12B blade. The incision is extended through the sulcus to the facial aspect of adjacent teeth, where vertical releasing incisions are made at the line angles. The mucoperiosteal flap is now carefully elevated using a fine Hugh-Freedy tissue elevator to expose the alveolar process beneath. A retraction suture in the flap ensures sufficient access to the implant surgical site. The palatal flap is cut using a 12B blade. The flap then is mobilized with the fine tissue elevator. The alveolar crest reveals the expected facial undercut. The crest measures 4.75 millimeters in orofacial width, suggesting that implant placement will be combined with a simultaneous GBR procedure to augment the bone deficiency. Using the same pair of calipers, the mesiodistal gap size measures 6.5 millimeters. This gap size requires a Straumann narrow neck implant with a 3.5 millimeter neck diameter. The mirror view demonstrates no vertical bone deficiency and sufficient bone height when compared to the CEJ of the adjacent teeth, shown by the periodontal probe. A large round burr is used to smoothen the alveolar crest and establish a nicely scalloped bony architecture in harmony with the neighboring teeth. The lateral view in the mirror confirms the scalloped alveolar ridge before the implant bed is prepared. Bone preparation starts with a small round burr to mark the implant position. This step makes it possible to correctly position the next drill. A 2.2 millimeter diameter pilot drill is used for the initial preparation. As expected, the drill perforates the facial bone plate because of the bony undercut. A 2.2 millimeter diameter depth gauge is inserted to check the position and the axis of this first preparation. The mirror view confirms that the depth gauge is in the correct mesiodistal position with sufficient distance to adjacent root surfaces. A periapical digital radiograph is made to check the distance between the depth gauge and the adjacent roots. The radiograph confirms that there is sufficient space to both roots. The access to the prepared implant bed is expanded with a larger round burr. Then comes the second pilot drill, which is 2.8 millimeters in diameter. It can be easily inserted and prepared to depth. A 2.8 millimeter depth gauge is inserted. It confirms the extended apical fenestration defect that will be augmented with the GBR procedure. In this case, the implant position is ideal in the orofacial direction. A profile drill is used to prepare the coronal aspect of the implant bed. A 12 millimeter Straumann narrow neck implant is now selected. The implant is slowly inserted to the correct depth using a contra-angle handpiece at a speed of 15 RPM. The mirror view shows the vertical position of the implant shoulder. Since this is a lateral incisor site, the shoulder is placed approximately at the level of the CEJ of the central incisor next to it. The insertion device is removed counterclockwise. The implant is well positioned, and its primary stability is excellent. A small occlusal screw is inserted into the implant. To achieve tension-free closure, the periosteum is released with a new number 15 blade. Several perforations are prepared with a small round burr into the facial bone wall around the exposed implant to open the marrow cavity. This opening will help the ingrowth of blood vessels during the early stages of wound healing. The flap is extended beyond the midline to gain access to the nasal spine as a donor site for autogenous bone chips. Autogenous bone chips are easily harvested using a flat chisel at the nasal spine. The grafts are collected and placed in a sterile glass dish. Additional grafts are collected from the apical area of the implant site with a Hugh Freedy bone scraper. Blood is aspirated from the patient and mixed with the autogenous grafts, and in a separate dish with bio-os granules. The mixture of the autogenous bone and blood is shown here. It will be directly filled into the fenestration defect to cover the exposed implant surface. The autografts are covered with bio-os granules to over-augment the alveolar process in the implant site. Bio-os granules are easy to apply and offer good volume stability due to the low substitution rate of bio-os. A resorbable BioGuide membrane is trimmed to the required shape using a pair of scissors. A trapezoidal strip is first cut. The membrane is held with a pair of tissue forceps to avoid any contamination with the talcum powdered gloves. The membrane is placed over the grafted site and adapted to the surroundings. Once the membrane is soaked in blood, it becomes self-adhesive and stabilizes itself. Excess membrane is trimmed away. A second strip of membrane is cut and positioned over the first layer. This further improves the stability of both membranes. To complete the surgery, the flap is repositioned and closed with interrupted single sutures. A primary tension-free wound closure is achieved using polyamide suture material. First, 2 crestal sutures are applied using 5-0 sutures. Numerous single sutures with 6-0 suture material, then close the releasing incisions. At the end of the surgical procedure, a pressure dressing is applied over the upper lip to control the swelling and to limit the risk of hematoma formation. Two months after implant placement, soft tissue healing is free of complications. A punch excision was used to reopen the site to apply a titanium healing cap. The implant is restored with a ceramo metal crown. The clinical status demonstrates how the peri-implant soft tissues have been blanched by the inserted crown. The detailed view at the 4-year follow-up examination confirms the excellent aesthetic result provided by the ceramo metal crown. The papillae are fully intact, and the midfacial gingival margin at the implant crown is correctly positioned. The periapical radiograph at 4 years demonstrates stable peri-implant bone levels in the crestal area. This offers excellent conditions for a long-lasting aesthetic treatment outcome. The lip line view shows that the implant-supported ceramo metal crown is well integrated in the dental arch from an aesthetic point of view.